Hi there, and today I will be presenting my research. I am representing the Faculty of Medical Sciences, the University of the West Indies Cave Hill campus. The title of my research is A Qualitative Exploration of the Barriers and the Facilitators of Exclusive Breastfeeding on the Essequibo Coast, Region 2 Guyana, South America, from the perspective of the health professional. The authors for this research includes yours truly, Alan Richmond, a medical doctor with a master's degree in public health, and co-author and research supervisor Dr. Natalie Greaves. I will now give a brief introduction and background to the topic. Firstly, exclusive breastfeeding refers to an infant only consuming breast milk for 6 months. Note well, no other liquid or food is given with the exception of medication or oral rehydration salt. A substantive body of research exists to show that there are numerous benefits to exclusive breastfeeding. These benefits can be categorized into benefits for infants and mothers. Infants who exclusively breastfeed generally present with lower morbidity rates for gastrointestinal, respiratory diseases, and they have excellent cognitive functions, motor skills, and high IQ. Some maternal benefits include postpartum weight loss. It also reduces the risk of breast and ovarian cancer, also type 2 diabetes. Although there seems to be undeniable benefits to exclusive breastfeeding, many mothers do not practice exclusive breastfeeding. Statistically, WHO reports approximately only 40% of infants are exclusively breastfed up to 6 months globally, while in Guyana the exclusive breastfeeding rate is 46%. In addition, it is essential to note that if exclusive breastfeeding rate increases, there will be a decline in childhood diseases. Congruently, there will be an economic benefit since less money will be spent on childhood diseases. The objective is to identify factors influencing exclusive breastfeeding for 6 months amongst mothers living on the Essequibo Coast, Guyana, as perceived by the health professionals providing their ante and postnatal care. A qualitative methodology was used for this research. Healthcare professionals who provided care to mothers with infants 4 to 6 months from 5 public primary healthcare centers on the Essequibo Coast were purposefully sampled. Healthcare professionals participated in individual, semi-structured, in-depth telephone interviews, which was conducted by a medical practitioner, which is yours truly, who was trained in qualitative research. The interviews averaged 28 minutes. They were audio taped, transcribed verbatim, and subjected to thematic analysis with constant comparison using an inductive coding method. Saturation was confirmed at the 11th interview. Data management was facilitated by Atlas TI software. We now arrive at the results section for the research. 11 interviews were conducted with various types of healthcare professionals, which included 1 doctor, 2 medics, 3 midwives, 1 nursing assistant, 4 community health workers. The interviews conducted and analyzed using constant comparison produced 14 basic teams, which are the facilitators and the barriers of exclusive breastfeeding, 3 organizing team, and a global team. The organizing team and the basic team were encapsulated into a global team, which reads, a mother's decision to exclusively breastfeed is a multifaceted phenomenon driven by a complex interaction between person, interpersonal, and environmental factors. Now we have table 1, which shows the organizing team, the basic team, and quotation to support the teams. For instance, the basic team, a mother's knowledge of exclusive breastfeeding, is supported by the quotation, and I quote, they say that the child is much more healthy, they love him, their IQ rate is very high, they still want to breastfeed. End of quote. Here we have a Venn diagram showing the intersection or the overlapping of the basic teams, which are the factors that influences a mother's decision to exclusively breastfeed. Table 2 shows a summary of the barriers only, the facilitators only, and the factors that acted both as the barriers and facilitators of exclusive breastfeeding. We're now going to discuss our results. The analysis showed that a mother's decision to practice exclusive breastfeeding is a multifaceted phenomenon driven by a complex interaction between personal, interpersonal, and environmental factors. These factors can be grouped into the components of the socio-ecological model, or known as SEM. This model shows the various levels of influences, which include individual, interpersonal, community, institutional, and policy. Now, a mother's knowledge of exclusive breastfeeding, which is at the individual level, was both a facilitator and a barrier to exclusive breastfeeding. Mothers that are educated about the techniques and the benefits of breastfeeding are more likely to breastfeed than those who are not educated. It is important to note that the interaction between the mothers, family members, healthcare professionals, and cultural and traditional beliefs influences mothers' decision to exclusively breastfeed their infants. Thus, there is an intersection between the mother's knowledge at the individual level, the family member's knowledge at the interpersonal level, and the healthcare worker knowledge at the institutional level. Additionally, grandmothers were seen as the gatekeepers of cultural and societal values. Thus, they were instrumental in the decision-making process. It was revealed that mothers adhere to their grandmothers, which is at the interpersonal level, which is influenced by the grandmother's cultural beliefs and tradition, which is at the environmental or the community level. As a result, some grandmothers will encourage mothers to practice exclusive breastfeeding, while others will encourage mixed feeding. Now, policies set by government do play a role in the decision process. Even though Guyana's government has a 3-month paid maternity leave policy to foster exclusive breastfeeding, it contradicts the Ministry of Health policy of 6 months. This current study also indicated that self-employed or mothers working in the private sector could not practice exclusive breastfeeding since they fear losing their jobs and becoming financially incapacitated. Moreover, some mothers also believe that if they decide to provide breast milk for their babies for 6 months via expressing the breast milk, the work environment does not provide the infrastructure where they can do the same. In addition, it does not provide the time for them to breastfeed or psychological support. Advertisement on formula feeds have influenced mothers' decision not to practice exclusive breastfeeding. Numerous advertisements on various media forms promote formula feed as the equivalent to breast milk since it contains DHA, which helps in growth and brain development. I recommend that we review the maternity policy. This policy contradicts the Ministry of Health's policy of exclusive breastfeeding for 6 months. Further research needs to be done on the impact of advertisement of formula feeds on mothers. Also, Guyana should consider reviewing the policy of the International Code of Marketing of Breast Milk Substitute. In addition, we need to formulate policies that influence exclusive breastfeeding that would target all the levels of influences. In conclusion, cultural, social, economic, and health services factors interact in a complex manner to influence the likelihood of practicing exclusive breastfeeding. These factors influence mothers collectively, and in some instances, they cannot be divorced from each other. I would like to thank the Ministry of Health Guyana for permitting me to conduct this study and the study participants.